Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
It's early days at the moment. As you might know, we've first started doing the DCD transplants only last year, the first one being in July, just over a year ago now. And since then we have carried out 6 who are all well at home with very good heart function. And thankfully others have followed suit. And so in England, there's a unit at Cambridge where I used to work before where they've done another 6. And then there's a unit in London, Harefield Hospital, where they've done 2. And all the patients so far are doing well. So we know that the short-term results are no different from those from brain-dead donors, but only time will tell what will happen in the medium to long term. It depends very much on the location of the donor and the recipient. If they happen to be co-located, as when the original heart transplants used to be done and with using DCD donors, then of course the costs and infrastructure requirements are not so great, because you can do it in the same hospital, almost in adjacent theatres, and you could use technology such as ECMO, which is a way of putting patients on bypass and cooling the body rapidly to preserve the organs. But sadly, these are very rare occurrences, and most of the time the donor and recipients are actually in disparate locations, which requires you not only to preserve the heart, but have means of transporting it, and therefore also to have means of assessing it. And that's where the problem lies, because the only technology we have at the moment that is currently commercially available is one which can bring the heart back in a beating fashion physiologically, and it is quite expensive. And I mean, you can offset the costs in terms of, economics and less time perhaps in ICU and so on, but the outlay initially is actually quite significant. Okay, so DCD transplant is one where the donor has got extensive neurological injury or a high spinal cord problem, and in whom there is no way of ever regaining any sort of quality of life. And therefore, because you have not been able to declare them brain dead, as in terms of the internationally recognized brainstem death criteria, then the only thing you can do in consultation with the family is to have a period of withdrawal of support. That typically means withdrawing them from the ventilator. And of course, if you do not have the basic reflex to even breathe, then the chances are then you will die. Of course, that time varies. So withdrawal of support in the form of a ventilator, and if, because there's no oxygen, then the heart will stop, and it is a cessation of a heartbeat, that allows you to declare the patient dead. Just as if somebody dies at home and the doctor comes and says this patient is declared dead because they have no heartbeat, no breath sounds, and are unarousable. It is exactly the same scenario. And then, of course, there's a period of 2 to 5 minutes, depending on the jurisdiction you're in, whereby you cannot do anything to the patient just to avoid the potential, the remote chance of auto-resuscitation of the heart, because we know that that does not happen after 2 minutes. And then there's an absolute rush to try and get these patients who are now donors following the declaration of death to the appropriate theatre for retrieval of the organs. So the best pathway always is one of a brain-dead donation, because that guarantees a very controlled situation whereby you can maximize the number of organs you can safely retrieve and translate that into a higher number of transplants you can achieve. In the DCD setting, which invariably and mandatorily has a time period called the warm ischemic time, when there's no blood flowing anywhere, and essentially the organs are engorged with still circulation, then acidosis builds up, and therefore certain organs, particularly the heart and the liver, are not resilient to this period of ischemia, lack of oxygen and blood flow, and therefore if you do not have the right time, if you cannot get there early enough after heart stops, then of course you may not be able to use the heart and the liver. There's much more time available for the kidneys and the lungs, which are more resilient as organs, and that's why we would allow up to 90 minutes or maybe even longer at times. But for the heart and the liver, it's 30 minutes.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
So you're doing a bit better with the gap in New Zealand than we are.
Yes, well, everything's relative, of course. I'm reminded of that old aphorism about in the land of the blind, the one-eyed man is king. So perhaps we are one-eyed Indigenous health deliverers in the land of the blind. We're doing better, but having said that, we're hardly meeting the challenge.
So it's about 9 years of a difference.
Yes, it is, which between Indigenous New Zealanders and Pākehā New Zealanders, that's right, which is a greater gap than between whites and American Indigenous peoples. So we don't take that as a particularly outstanding achievement.
Now, why do you think that is? Because the reason you think that is, and it should be said that you're Maori yourself.
Yes.
Why you think that is, because a lot of doctors, pharmacists, primary healthcare practitioners who are watching this, clinicians who are watching this, will say, well, look, it's all up to housing, finance, economics, employment. We've got very little role to play here. But from the perspective of a Maori physician, also a Maori health educator, what is the role for people watching us converse?
Yeah, I think you're right. By the way, they are right. Housing may have a greater bearing on referral to hospital than acuity of illness, but putting that aside, we have a maldistributed workforce in New Zealand as you do in Australia. 15% of New Zealanders are Maori, about 2.5% of the health workforce is Maori. New Zealand has 2 out of every 3 rural doctors are trained overseas. There's a major cultural disconnect between the communities that these doctors serve and the communities that the doctors originate from. And I'll give you some examples for that. Very subtle differences in philosophies, understandings, concepts can end up with very major differences in health understandings. And some of the barriers to health access are actually quite subtle.
Can you give me a tangible example?
Yeah, I can. I'll give you an example from my own family, for example. One of my aunties died of lung cancer. Well, the first issue is Maoris smoke 2 to 3 times more often, 2 to 3 times more than Pākehā New Zealanders. And of course, the Pākehā perspective in that regard is we need another white middle class health awareness campaign.
Don't smoke.
Exactly.
As
if Maori don't know they shouldn't smoke. Or, you know, don't eat McDonald's and run around the block. It beggars belief to think that Maori don't know. The question, of course, why...
And the same would go for Aboriginal people.
Absolutely. And you see, you can intelligently articulate, yes, it's a good idea to not eat McDonald's and run around the block, but on Saturday when there's a funeral, I go to the tangi. I'll know exactly how important the person is who's died by the nature of the food there. I can look around the room and I can say to you, Norman, that's the most important person here, by the nature of the food served to that particular person. And it's the deculturation of food and the sort of models of health and health perceptions that matter. I'll give you another example before I get back to Sally. I haven't forgotten Sally. We were offered a lot of money to look at skin cancer awareness in outdoor workers. And this money was offered to us by the Cancer Society. And their idea was that they'd have a slip, slop, slap campaign to encourage people to work outdoors to avoid non-melanoma skin cancer, which is a good idea, isn't it? And they asked me what I thought would be interested in the money. I said, no, it's a complete waste of time. Because the person you're trying to influence is going to go to the pub tonight, excuse my language, get pissed and drive home drunk. He'll go home with a woman he's never met before. They'll have sex at night without a condom. He'll drive to work the next day still hungover. He and his mates will smoke a couple of joints on the way to the forestry site, and then he'll climb a tree with a running chainsaw. Now,
what's a bit of sun?
Precisely. You imagine that in your white middle class intention way, you rush above the tree saying, please, please.
There's some factor of 30 here. If you could just stop the chainsaw for a moment.
So, health at risk perceptions, we keep taking a white middle class view of what health risk perceptions are and what health risk behaviours are, and assume that if we articulate them in our idiom that these will be understandable to anybody else. So the first thing about Sally is that she smokes. Whatever the idiom is of the anti-smoking campaign, it's not a Maori idiom. The second thing is she doesn't present to anyone until she has very advanced disease. And I said to her, you silly old bugger, what are you doing up here in the far north getting this sick? Before you went and saw somebody. And she said, well, Desi, you know, she's talking to me now as I'm a 5-year-old. And
you will always be a 5-year-old.
Absolutely. Breathtakingly stupid, hence she's got to speak slowly to me. She said, how could I possibly go down to the nearest town, which is Kaitaia, and take my blouse off in front of those men? Because there were 2 doctors in Kaitaia. One was Indian and one was South African. And for her, the idea of visiting either an Indian or South African doctor and taking her blouse off was just a barrier too far. So in that case, we had 2 issues. One was the very nature of the anti-smoking campaign, which has had little traction around the Maori. The second thing is, to her, the barrier of going and seeing men from such a dissimilar culture to her meant that she just was not going to go into that situation.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.